This is probably going to be a difficult question about how, but I want to now focus
Sure.
on relapsed refractory CLL. And in my mind, what makes it difficult is that we may be seeing patients in the modern era who have had long responses to or have received prior immunochemotherapy, and they're progressing. On the other hand, we now have BTK inhibition as first-line therapy. How do you decide what to do for a patient who has relapsed refractory disease, given that they're coming at you from all different types of pre-therapies?
I think it's very important. I think we didn't touch upon that. Historically, we went from short therapies, chemoimmunotherapy, like a time-limited therapy, and the paradigm would change with the BTK introduction, the BTK approvals, right? So we changed from time-limited therapy to prolonged therapies, for therapies until progression on or unacceptable toxicity, which really completely changed the way that we really, control CLL. Now with this new really regimen, including venetoclax, we're going back to the old paradigm. It's not so old, the time-limited therapy. So these days we really can move between these two paradigms, and in the future we're gonna maybe be able to combine. So at the end of the day, when we really discuss relapsed refractory CLL therapy with patients, we really encounter the same conversation. We have very, very good drugs who really maintain, or while patient checking the drug can really have very, very long duration. We are presented in this ASCO, the first Resonate trial with a PFS, very, very long PFS, almost 44 months. But also we have the Murano study that was reported at us, who also really prolong a very, very long time to progression, right? Which one we're gonna really elect? Obviously, once again, it's a decision I need to make for each patient. In my opinion, not every patient could be given the same medication. Because CLL at the same time, and when we're discussing, Harry, why we treat CLL, we don't treat CLL for the same reason. We have patients with very bulky lymphadenopathy who really do fantastically with ibrutinib or with any kind of BTK inhibition, but also we see patients with cytopenias. That also the goal is to really empty this bone marrow with very, very good drugs. So I think we're gonna really define in the near future, also customize why we're gonna treat patients, right? Not CLL relapse refractory. Okay, what is the main issue? What is the problem that we're gonna really accomplish? And at the same time, also understand that some patients, because the genetic feature, they may require therapy for life, while others, they may really require therapy for a short period of time and then wait until they progress and do it again.
Okay, before we leave immunochemotherapy in the
Sure.
distant past, are there patients who've been treated with immunochemotherapy who've had a long remission where you might be tempted to treat them again with the same agents? Do you think that's dead?
That's a great point. I think chemoimmunotherapy is going to be gone very, very soon. But you have a good point. The old time we say, well, if an FCR patient has more than 3-4 years, why we shouldn't do it again? I think what we have learned is that when we do fludarabine and other agents like bendamustine, they really, really give us a good result in the short run. But I think what we always underestimate what is the damage that we do to the genetic or the genome of the CLL, and how we're gonna change, likely, although maybe we need more data, the natural history of this patient in the long run. So I think it's the reason, try to avoid damage to the cells and also damage to the immune system. I think it's going to be an important part of really looking forward about the therapy in the relapsed refractory patients.
Well, let me provide a third nail in that coffin,
Perfect.
okay? From my perspective as a myeloid leukemia doc,
Absolutely.
you and I both know that these drugs
Sure.
are mutagenic and genotoxic.
Absolutely.
And may lead to MDS and AML.
Absolutely,
Yeah.
absolutely. And I think, as you see, unfortunately, sometimes we see this consequence like 10-15 years after these patients were exposed.
Okay, so we are going to talk about, well, in the relapsed refractory setting, we have BCL2 inhibition, we have the BTK inhibitors, we have PI3 kinase delta inhibitors. Is there any kind of assay that you can do that might help predict for response to one or the other? For example, do you test for BCL2 or BH3 expression?
That's a great point. So right now we know that it's consistently in any trial that has been done with new drugs, with BTK, with BCL2, with PI3K delta, there is not really a factor who really predisposed to have a better response to a subtype of CLL versus another. So we know that the classical one is the example of IGBH mutated versus unmutated. We know that chemotherapy, people will do well, but they start to really separate the curves in PFS. Now, with BTK inhibitors, with BCL2 inhibitors, we don't really see a difference. The effectivity is the same. Same happened with TP53, deletion of 17p. And very interestingly, even in deletion of 11q, we even see a better outcomes with these new drugs that we still don't understand and we are really studying very, very deeply. So I think right now, as far as I know, we don't have any predictive factor in genetics or mutation who can tell us, oh, these patients are going to work better in this drug versus another drug.